Hi class, this is lecture number 2 on respiratory system. So in this one, in this video we are going to discuss medications for lower respiratory tract. And also we are going to review Professor Lee's PowerPoint. So I'm going to screen share and we are going to go and look from the book, chapter number 55, and then we're going to discuss PowerPoint from Professor Lee's class. So what are the drugs that are used for lower respiratory tract, right? So that this PowerPoint basically talks about that area. Drugs acting on lower respiratory tract, okay? So lower respiratory tract looks like this. We have bronchioles and then you have air sacs at the end of the bronchioles, which technically are called alveoli. And then these bronchioles, sometimes they squeeze and they shut down, and that causes the air to be trapped. And this condition is called bronchospasm. These bronchospasms could be because of inflammation, which is bronchitis. It could be just because of allergies. It could be severe mucus, or it could be just a muscle spasm because of severe allergies. So there are different reasons where this airway could be narrowed. It could be because of allergic response, which is just a spasm of muscles. It could be inflammatory responses, which is infection. Or it could be some cancer or like some kind of tumor sitting in there causing this airway to be blocked. So, those are all conditions of lower respiratory tract, and that does not allow a lot of air exchange. Manifestation of COPD is what? Chronic obstructive pulmonary disease. In this condition, air is trapped in the lower respiratory tract. And why? Because the airway becomes narrow because of chronic inflammation, chronic irritation, and it causes that airway to be narrowed. Then the alveoli degenerates and fuses together. Exchange of the gases is greatly impaired. Prevention and treatment of COPD. Reduce the environmental exposure to irritants, smoking cessation, filter allergens from air, avoid exposure to the known irritants and allergens, open the conducting airways through muscular bronchial dilatation, decreases the effects of inflammation on the airway lining. Now, respiratory distress syndrome is distress syndrome could be related with some kind of inflammation, infection. Characteristics could be progressive loss of lung compliance and increasing hypoxia, means patients slowly becoming shortness of breath, difficulty breathing. Causes could be cardiovascular collapse, major burns, severe trauma. A rapid depressurization is slowly, like patients not able to breathe, and then it causes dyspnea, shortness of breath, difficulty breathing. So slowly causing problems in breathing. Treatment, reversal of underlying causes combined with ventilatory support. So there's times when we have to put them on ventilator, put a tube in their throat, put them on a machine, and that is because they can't breathe. Their lungs are not functioning. So some of the medications which we use are bronchodilators that will dilate the bronchial tract. Those are bronchodilators, or anti-asthmatics. Now what are those medications? One is xanthines, one is sympathomimetics, one is anticholinergics. Xanthines, some of the portion, one of the examples is caffeine. Caffeine is a bronchodilator. If you drink like a cup of coffee, it causes some bronchodilation because it's sympathomimetic, but it could also cause tachycardia. There's times when we feel anxiety. That is all part of caffeine, stimulating sympathetic nervous system. Next is theophylline. Theophylline is a bronchodilator. It dilates the bronchus at the all the junctions wherever patients having severe bronchial constriction. So theophylline, aminophylline are certain methylxanthines that could be given. There are times when we give them in a drip form, like IV drip form, right? Okay, so methylxanthines, the direct effect on smooth muscles of respiratory tract, both in bronchi and blood vessels. Indications include sympathomimetic relief of prevention of bronchial asthma or reversal of bronchial spasm associated with COPD. Pharmacokinetics, narrow therapeutic margin, rapidly absorbed for the GI tract, and metabolized in liver and excreted. All medications are metabolized in liver and excreted in the urine. Contraindication, when should you not give it? When patient has heart problems, stomach problems, severe respiratory dysfunction, baseline renal kidney problems, alcoholism, hyperthyroidism. Adverse effects could be related to theophylline levels in the blood. GI upset is nausea, vomiting, irritability, tachycardia to seizures, brain damage, and even death. Drug-to-drug interactions, many drug interact with xanthines and substances in cigarettes. That's why we say no smoking, no drinking whenever we're taking any medications. Now, assess history and physical examination, known allergies, check for any peptic ulcer disease, gastritis, renal and hepatic dysfunction, and coronary disease. Monitor for blood pressure, pulse, cardiac auscultation, peripheral perfusion, and baseline echocardiogram. Skin, check for any skin disorders or any liver and kidney function abnormalities. Check for baseline blood levels of theophylline. Now, theophylline also, it's a relief for bronchospasms. It could be given for bronchial asthma, reversible bronchial spasm associated with chronic bronchitis and emphysema. Directly relaxes the bronchial muscles, and it increases the vital capacity, which is technically the breathing capacity of the lungs. So it helps the lungs to breathe better, to open and close better. It also increases the force of diaphragmatic muscles. Now, adverse effects could be irritability, restlessness, dizziness, palpitation, life-threatening arrhythmias, loss of appetite, proteinuria, respiratory arrest, fever, and flushing. Sympathomimetics, some medications that will help sympathetic nervous system responses to be stimulated, and dilatation of bronchi. Some of the medications which we take for when patients coughing, let's say a patient having asthma, they can't cough, and sometimes we give them something so they could breathe better, inhaler. So that inhaler could be albuterol, right? Albuterol, levalbuterol, then ephedrine, epinephrine. Then we have isoproterenol. Then we have salmeterol. Terbutaline, very commonly used medication. So these are all bronchodilators. Technically, they dilate the bronchus, help people to breathe better. Very commonly used drugs. Their action is to beta-2. They're beta-2 adrenergic agonist. Right? Indication is for acute asthma, bronchospasms, and acute and chronic asthma. Prevention of exercise-induced asthma. Pharmacokinetics means rapidly distributed after injection, transformed in liver to metabolites that are excreted in the urine. And then contraindications, it depends on severity of underlying condition. Sympathomimetic stimulation, CNS stimulation, which is brain stimulation, GI upset like stomach upset, cardiac arrhythmias, hypertension, bronchospasm, sweating, pallor, and flushing. Drug-to-drug interactions, general anesthetics. Always for all medications, check for history and physical, check for allergies, check whether they have their smoke or not, are they pregnant, are they lactating, they have baseline cardiac disorders, do they have any abnormalities in heart beating, do they have any hyperthyroidism, refluxes, and orientation, and then do they have any abnormalities in this orientation status. So, and then appropriate lab values. Epinephrine. Epinephrine is for treatment of anaphylactic reactions, acute asthmatic attacks, and relief from respiratory distress of COPD and bronchial asthma. So for this epinephrine is specifically for severe allergies. So some people carry EpiPen. If you have noticed, like some people when they go in the let's say someone's allergic to pollens, and they go in the field, and then they feel shortness of breath, difficulty breathing, and they usually carry an EpiPen, and they will just put it on their thigh, and then give the medication, and they usually feel better. They feel like they can breathe better after the injection. So that is severe allergic responses because epinephrine will cause bronchodilation and help people to breathe better. So that is sympathomimetic prototype, right? So epinephrine is a very specific medication. EpiPens, people carry EpiPen for severe allergies. So for an example, I will just quote an example of one of my friend's daughter. One time we went to the forest, and then she started to have allergies. She was itching, and she came to me. She's like, "Auntie, I'm feeling itchy." And I'm like, "What happened?" She's like, "I think I have a bee sting on my stomach." And I'm like, "What?" And then she's generally allergic to a lot of things. So I'm like, so I'm like, "What's going on?" So she goes, "Oh, I'm feeling itchy, and I feel shortness. I think my lungs are closing, and I feel I can't breathe." So I was like, "Okay, just pull out your Benadryl." So I knew that she had Benadryl. I'm like, "Pull out your Benadryl, take your Benadryl right away." And she also has EpiPen. So I'm like, I might have to give her EpiPen. So, but she took first Benadryl. She has liquid Benadryl. And how old is she? She's a 15-year-old. So she took her 25 milligrams of Benadryl, and then I'm like, "Are you feeling better in 5 minutes, in 10 minutes?" She's like, "No, I still feel tight in my chest. I can't breathe." I'm like, "Take the second one." So she took the second liquid Benadryl, and within 5 minutes she was feeling better. She's like, "Oh, I can feel better. I could breathe better." So that is liquid Benadryl. But then if you can control those shortness of breath, difficulty breathing with Benadryl, then you have to do EpiPen. So EpiPens are just like you jab them on the thigh, and then they're very very strong and very fast. And people who have allergies, like if you have any kids or family members who are allergic to certain things, you know that they carry EpiPen in their baggies, everywhere, wherever they go, because there's time when they have unidentified allergies and they have to use them. So that's a story related with epinephrine. Okay, let's look at this question. The adverse effect of xanthines are related to theophylline levels in the blood and include blood-brain damage. Yes, it is related to theophylline. High blood levels could cause theophylline toxicity. Technically, that's what they're asking you. And GI upset, nausea, irritability, tachycardia, or seizure, brain damage, and even death could be other parts of this theophylline toxicity. Patient who cannot tolerate sympathetic effects of sympathomimetics respond to anticholinergic drugs. So sometimes we cannot give them albuterol. We give them ipratropium, which is also called as Atrovent, which is also an inhaler. It comes in as an inhaler form. So let's say if they have asthma and they can't tolerate albuterol, because albuterol gives them palpitation or increases their heartbeat really fast, we give them something called as ipratropium or Atrovent, very commonly used drug. Then Spirivia is another commonly used drug, also called as tiotropium. So ipratropium, tiotropium, these are just a common example of bronchodilators which are used when we cannot use albuterol. Okay, actions are anticholinergics that block vaguely mediated reflexes by antagonizing the action of acetylcholine. Indications in a maintenance treatment of bronchospasm associated with COPD. Pharmacokinetics, onset of action in 15 minutes when inhaled. Peak in 1 to 2 hours. Duration of action is 3 to 4 hours. Caution: any conditions that would be aggravated by anticholinergic effects of the drug. Adverse effect, bad effects related to anticholinergic effects of the drug could cause dizziness, headache, fatigue, nervousness, dry mouth, sore throat, palpitation, urinary retention, drug-to-drug interactions, and other anticholinergics. Assess. Check for history and physical, baseline, check for acute bronchospasm, bladder neck obstruction, or prostatic hypertrophy, orientation, affect, and reflexes. Pulse, blood pressure, respirations, adventitious lung sounds, and urinary output. An example, ipratropium. Ipratropium is also called as Atrovent. It is for treatment for bronchospasms, which is technically could be related with asthma, it could be related with COPD, seasonal allergies, rhinitis, right? And then it could cause adverse effect at the bottom is nervousness, dizziness, headache, GI distress, coughing, and palpitation. So let's talk about some steroids. There's times when we have severe bronchospasm, but it is because of severe allergies or inflammatory responses. We give them some steroids to reduce the inflammation and to reduce the allergic responses. So beclomethasone, flucortisone, triamcinolone, these are very commonly used medications. They will increase the inflammatory responses, but they could increase the infections because they lower the immunity, they're immunosuppressants. So adverse effects could be sore throat, hoarseness, coughing, dry mouth, or any fungal infections. We would always check the baseline history and physical. We will check for allergies. We will check for systemic infections, pregnancy, lactation. We will check for adventitious lung sounds, which is what is their lung sounds like, and what is their vital signs. Okay, next one is budesonide. Budesonide is just another steroid. And all steroids, they're, for anti-inflammatory. Remember, anti-inflammatory, they're immunosuppressants, they suppress the immunity. And the third one is they cause hyperglycemia. So signs, other adverse effects could be irritability, headache, rebound, congestion, and local infections. Act more specifically at the site of problem associated with asthma, zephyriculus, monticulast. They come under leukotriene receptor antagonists. This is another type of medication which we give for asthma. What do they do? They selectively and competitively block and antagonize the receptors for production of leukotrienes. Indications. What is the indication? Treatment of bronchial asthma. We give it for asthma. Pharmacokinetics. It is rapidly absorbed from the GI tract and extensively metabolized in the liver, and just like all other medications. Cautious with pregnancy, lactation, and kidney problems or liver problems. Adverse effects could be headache, dizziness, myalgia, nausea, diarrhea, elevated liver enzymes, vomiting, and generalized pain. Drug-to-drug interactions could be propranolol, theophylline, and then terfenadine or warfarin, calcium channel blockers, cyclosporin, and aspirin. We always with all medication, remember a history, physical, and allergy check, a baseline renal function, kidney function check for their lungs and their orientation status, and then baseline vital signs. An example is Zephyriculus. Okay, prevention of long-term treatment of asthma, mostly for children above age of 5. What does it do? It blocks the receptors for leukotrienes, which are component of slow-reacting substances for anaphylaxis, blocking airway edema and processing of inflammation in the airways. Adverse effects could be headaches, dizziness, nausea, generalized pain, fever, and infection. Mast cell stabilizer, something that will stabilize a mast cell, right? So that's the mast cell stabilizer. Usually treatment for rhinitis, asthma. One of the examples is cromolyn sulfate, right? Lung surfactant, something that will hold the lining of the inner alveoli, right? Those are called lung surfactants. So naturally occurring compounds are lipoproteins containing lipids, lipoproteins that reduces the surface tension with the alveoli and allowing the expansion of the alveoli for the gas exchange, such as galfactant, right? So those are basically surfactant. What do? They will keep that inner lining of the lungs strong, and so it will keep it open. So they want those alveoli or those air sacs to stay open, right? Contraindication, not necessarily present, but adverse effects could be hypotension. It could cause some heart defects, such as patent ductus arteriosus is a heart defect for children. Then intravenous hemorrhage, pneumothorax, which is air in the lungs, pulmonary air leak, hyperbilirubinemia, increased amount of yellow pigmentation under the skin causing jaundice, and sepsis is an infection. All medications, we check for H&B, we check for allergies, vital signs, what is the baseline condition. Next one is, then we have Baractant, which is pretty much the same medication, similar. Question: which of the following is a contraindication for using lung surfactant? When do you not use it? Prematurity, older adults, no contraindication, COPD. Technically, not necessarily a lot of contraindications for lung surfactants are used as an emergency drug in newborns, and there are no contraindications. Nurse is caring for a patient taking budesonide, right? What would be an appropriate nursing diagnosis for this patient? Risk for injury related to immunosuppression. So they're asking, do you know, is budesonide and a steroid? Less CNS effects, CVS effects, or does it cause age-related infections? So it causes immunosuppression. Yes, all steroids cause immunosuppression, anti-inflammatory processes, and also the third one is they will cause increased high blood sugar levels. They increase the sugar levels. All right, so this was just the PowerPoint from our chapter number 55 from book. The next portion of this lecture is we're just going to review Professor Lee's PowerPoint, which most of your exam questions are basically based on this PowerPoint. So it's just a review of all of what we have studied since the beginning. So let's review this one. This is Professor Robbie Lee's. Okay, so let's talk about upper respiratory. So it's a recapitulation of upper and lower respiratory tract. Okay, so upper respiratory tract, what could be conditions? Some common cold. Rhinitis is inflammation and stuffy nose, right? Inflammation of nasal mucous membranes. Sinusitis is inflammation of sinuses, which are just little, underneath those cheeks. Patients have infection, so that's sinusitis. And pharyngitis is in a sore throat or inflammation in our when you have difficulty swallowing and in our throat, so that's pharyngitis. Common cold, contagious, how long does it last? 1 to 4 days, sometimes 1 week. During first three days of cold, transmission could be, how does it transmit? So if, let's say, if a spouse has common cold, obviously the other spouse will get it, so it's airborne, right? Sometimes it's through sneezing and coughing. So if someone's sneezing and coughing, we say just cover their face or just wear a mask, so the other people won't get it, because the transmission is through viral, through the air, droplet. So symptoms could be nasal congestion, nasal discharge, coughing, increased mucosal secretions, sore throat. So what medications do we give? We give them some antihistamines to reduce the allergy, decongestant to help their lungs feel not so congested. Antitussive are cough suppressants, remember that one. And expectorants is the medication that will help them to cough out when they have thick secretions. Expectorants are to help them to cough out the mucus. All right. So 2 types of histamines. Histamine 1 and histamine 2. Histamine 1 is the receptors, causes extravascular smooth muscle, including inner lining of the nasal cavity to constrict. H2 receptors causes an increase in the gastric secretions, which can cause a peptic ulcer. H1 blockers or H1 antagonists are used for a cold and decreases the nasal pharyngeal secretions by blocking H1 receptors. And do not confuse H1 and H2, right? So first generation, it causes drowsiness, dry mouth, and other anticholinergic symptoms. Also decreases the nasal itching and tickling that could cause sneezing. Most over-the-counter medications, cold remedy contains of first generation antihistamines. An example is Benadryl. As you know, a specific example for allergy is Benadryl. That is like a first-line treatment. Like if someone is having allergy, we usually give them Benadryl. Second generation, non-sedating antihistamines have few anticholinergic effects. Could be Allegra or Claritin. So a lot of people use Claritin. Benadryl, diphenhydramine, it is used to treat allergies, rhinitis, itching, all kinds of allergies. It also prevents motion sickness, for sleep aid, and antitussive. What is antitussive? That suppresses the cough. It could cause drowsiness, right, sleepiness, assess the bladder function, and evaluate for distension, as Benadryl can cause urinary retention because it is an anticholinergic medication. Children are more sensitive to Benadryl. They may have an opposite effect, cause child to be more agitated, may cause nightmares, nervousness, and irritability in children. Benadryl. Nursing management would be make sure that we can give it through IVP or an IM form. It should be given with food. It could cause GI distress. Avoid operating more. So whenever a person takes Benadryl, they feel sleepy. We want to make sure that they're not operating any heavy machinery, they're not driving. Avoid alcohol because it adds on the effects of CNS depression. And use hard candy, which could be for dry mouth. Remember, anticholinergic effects are dry mouth, blurred vision, urinary retention, constipation, and photophobia. And that is a standard when we say, oh, this medication has anticholinergic effects, that means it can do all of that. Nasal and systemic decongestants. Okay, nasal congestion results from dilatation of nasal blood vessels caused by infection, inflammation, or allergies. The dilatation causes fluids to move into the tissue spaces, resulting in swelling of the nasal cavity. Nasal decongestants causes vasoconstriction of the capillaries within the nasal mucosa and have fewer side effects than systemic decongestants, frequently used for decongestion, using more than prescribed longer than 3 to 4 days. So decongestants, remember, for nasal congestion we use decongestants. It will reduce the amount of congestion. So for decongestants we have systemic that will relieve the nasal congestion. Example is ephedrine, neosifrine, and Sudafed. Side effects would include use of nasal decongestants such as little as 3 to 4 days can cause rebound nasal congestion, can cause patient to be jittery, nervous, restless until the body adjusts. Blood pressure and blood sugar levels can increase. Decongestants are contraindicated in patients with hypertension, cardiac diseases, hyperthyroidism, diabetes mellitus. Drug interactions include pseudoephedrine may decrease effects of beta blockers. MAOIs may increase the possibility of hypertension and dysrhythmia. Avoid large amount of caffeine, tea, as this may increase the feeling of jitteriness, nervousness, and may cause palpitation. Antitussives acts on cough control centers. So basically, what are antitussives? They're cough suppressants, right? They will slow down the coughing. 3 types of antitussives are non-narcotics, narcotics, and combination preparations. Robitussin, as we talked about, is dextromorphan. It suppresses, also could be combination with the narcotic. Suppresses the cough center of the medulla and reduces the viscosity of tenacious secretions. Expectorant, something that will have people cough. Guafenicin is one of the examples. Hydration is the best natural expectoration for patients who are not able to cough out secretions. We give them more water with guafenicin. Lower respiratory tract, we could have, a patient might have conditions such as COPD, bronchitis, emphysema, or asthma. They could have some edema in the lungs, inflammation, pulmonary fibrosis, cystic fibrosis, pneumonia, lung tumors, myasthenia gravis, and thoracic deformities. Albuterol. So albuterol, we were talking about, it is a bronchodilator, it's a sympathomimetic, so it will open the airways, but it could cause tachycardia. Heart rate might go up. So it could cause nervousness, tremors, tachycardia. It may be monitored for, patient might need to be monitored for these side effects, right? Singular, it is a leukotriene receptor antagonist. It reduces the inflammatory symptoms of asthma triggered by allergies and environmental stimuli. Singular prevents bronchospasm by inhibiting smooth muscle contraction and bronchoconstriction. Used as a maintenance drug for asthma. Not used for acute attack of asthma. Teach the patient to take an inhaler for active attacks, right? Theophylline. Theophylline, it relaxes the smooth muscles of the bronchi, bronchioles, and pulmonary blood vessels, which results in bronchodilation. Has serious side effects such as dysrhythmia, convulsion, cardiopulmonary collapse. Because of side effects, it is usually prescribed to patients with chronic stable asthma. Contraindicated in patients with seizure disorders and cardiac, renal, and liver disease. This medication has diuretic effects, therefore instruct the patient to avoid caffeinated products like caffeine, tea, soda, chocolate, and increase fluid intake while on this drug. Advair, it's a glucocorticoid, it's a steroid, so it will reduce the inflammatory responses and it comes as an inhaler form. Must rinse the mouth after Advil to avoid breaking down of oral mucosa. Mucomist that acts like a detergent or liquefy and loosens the thick secretions. And it helps the people to expectorate, like cough it out, liquefy it and cough it out. So it could be, so acetylcysteine is one of the mucolytic. It is used when you can hear audible choruses, wet lung sounds without a stethoscope. So that is it for Professor Robbie Lee's PowerPoint, just to complete the presentation. So this was just an overview of both of the chapters. I know that this respiratory system is not as big as it seems. So both of these videos are like 35 minutes and 30 minutes. So do the worksheet after the video. Please submit your worksheet by the end of the day of your lecture, and if you submit your worksheet, I will definitely count it as you know, if there were times when I was like looking for a worksheet and I was like, why did this person not submit their worksheet? So please do that. It's only 5 to 10 questions, not more questions. Please do your worksheet and submit on time. And write down your questions. Remember, we have a question and answer session on Wednesday 6 p.m. So if you need tutoring, Wednesday 6 p.m. I will open a Google Meet a link so we can talk. And if any other questions, write them down and discuss in the post conference. Okay, take a little break, 15-20 minutes break. This could be a little small class. Submit your worksheet and that should be good. Thank you for listening. All right.